Good afternoon, everybody. If you could grab a seat, I thought we'd get started because even though it looks beautiful outside, I just walked in. It's really hot and really, really humid. So thank you for choosing to be with us in a summer afternoon. I am very excited about the program. My name is Chad Brummett. I'm one of the co-PIs of the Michigan Opioid Prescribing Engagement Network, Michigan Open, which some of you might have heard about. If you haven't, you can go to michiganopen.org, learn more about us. Pleased to co-sponsor today's event with the University of Michigan Injury Center. Obviously, this is a topic that has received considerable attention in the lay press and around the community, something that I think will only become more important with time. Prescription drug monitoring programs are an essential way forward as we combat the opioid epidemic, and we're very lucky today to have one of the nation's experts in prescription drug monitoring programs here with us today, as well as someone from LARA, Kim Gedicka from LARA here today to talk to us about the new MAPS program and the opportunities we have. So first up, I want to just kind of jump straight into it. Actually, if you haven't seen yet, we do have some materials in the back from where you signed in. There's some information about MAPS from LARA. We have some really nice materials from the Injury Center. If you haven't taken 2 minutes to read some of these fact sheets are incredible. They're really well put together. Many of them come from CDC. There's 3 different fact sheets as well as a brochure from the Injury Center. And then for those who haven't seen this, please go to the Michigan Open website, download it, disseminate it, share it. This is a step-by-step on how to safely dispose of your drugs in the state of Michigan. This is a step-by-step on how to find DEA-registered sites in the state of Michigan and safely dispose of your medication, something that we're very passionate about in Michigan Open. Our first speaker today is Rebecca Haffajee. She is an assistant professor in the Department of Health Management and Policy here at the University of Michigan Public Health. She received her law degree, a master's in public health, and her PhD in health policy, all from Harvard. So clearly an underachiever. Before entering academia, she practiced as a healthcare associate in the law firm of Ropes and Gray for several years. Her research details legal analysis with empirical investigations in terms of the relationships between law and health. And in particular, she's been focused on behavioral health and pharmaceutical policies involving things of mental health, substance abuse parodies, and laws intended to curb opioid abuse and addiction. She has studied the policy evolution and legal issues associated with the effects of prescribing prescription drug monitoring programs. She provides PDMP policy recommendation to government and has published articles in New England Journal, JAMA, and the Hastings Law Journal. So we sometimes forget right here in Michigan we have some of the nation's foremost experts in these topics, and we're really lucky to have Rebecca here today to kind of get us started and talk about why PDMPs are important. Rebecca?
Thanks so much for that introduction, Chad, and thank you to IHPI, Michigan Open, and the Injury Center for inviting me to speak here. It's a great opportunity. I'm really just going to lay the stage for Kim because she has much more detailed information about MAPS, but I'm going to talk more generally about PDMPs, the policy landscape, and best practices. I won't belabor this point because I think we're all pretty familiar with it. Drug overdoses are now the leading cause of death among Americans under 50. In 2008, they surpassed motor vehicle injuries to become the leading cause of injury death in the US. And a large reason for that is opioids. So on the left-hand side here, you can see in 2015 at a county level, drug overdose deaths. You see in the dark red those counties that had really high rates of overdose deaths. You can see the Rust Belt, New England, parts of Michigan, and then some pockets in the West had particularly high rates of overdose deaths. On the right-hand side, you see the New York Times actually went county to county and chronicled overdose deaths in 2016, found that more than 59,000 people had died from drug overdoses in 2016, 2/3 or 40,000 200,000 of those were opioid related. And so, we continue to have a really big epidemic, and it's getting worse. I will say that a lot of that precipitous incline in the last few years has been attributable to heroin and fentanyl and illicit sources. And opioid or prescription opioid related deaths have actually kind of leveled and decreased a bit, as has prescribing. This is hot off the press from CDC, just came out. They did another look at opioid prescribing using IMS Health data. This is at a county level, and you can see those that are really dark are those that are very high, including a number of pockets in Michigan. And they found now, we reached a peak in opioid prescribing around 2010, at which point we had quadrupled the rate from 1999. Now we've gone down a bit. We're now at 3 times the rate of 1999, still very high, but we are doing some things working to curb prescribing somewhat, but the concern still remains that there's wide variation across counties and not really a good reason for that. They found that rural areas, white, low SES were particularly correlated with high opioid prescribing. And this shows you Michigan. I only had through 2013, but that basically Michigan, the death rate attributable to drug poisonings has increased by 385% from 1999 to 2013. And on the right-hand side, you can see Michigan in blue as compared to the nation in black. And so we are surpassing the rate of increase in the nation. We're now in the top third of states. So lots of policy and other types of interventions that we have been implementing at every level to try to curb this epidemic. You can see here on the left-hand side is sort of an epidemiological framework of categorizing these types of prevention measures. You can see at the bottom we might start with clamping down on the overall supply at the population level. Then we might move to a primary prevention, reducing initial exposure of individuals, then to a secondary prevention where we would think about somebody who's been exposed but is not yet addicted or dependent on the drug and preventing further use. And then at the top of the pyramid are those people who are already, disease is firmly entrenched and they are addicted or dependent, have opioid use disorders, and are in need of treatment. And so we've been doing things, and on the right-hand side, I've put in some of the interventions at each of these levels. I think PDMPs really fall, I think, along the secondary prevention level, but I think they can be thought of as primary and as tertiary prevention measures also. Mainly, we're thinking about identifying those people who are using at high rates or where there might be a drug interaction that's happening, and you can see that in the PDMP data, and I'll go into what that includes. But you could also think about preventing initial exposure for those people who might not be good candidates for opioids. I also think they're heavily underutilized for getting people into treatment and identifying those people who might be really good candidates for medication-assisted treatment therapy and getting them referred. So what are PDMPs? They are electronic systems that digitally store, monitor, and analyze controlled substance information, and it's entered at the point of dispensing, so by pharmacies. They're implemented typically at the state level, although there are a few, like Missouri didn't have a state, it's the only state without one as of now, and so some, like St. Louis, had decided to implement a system, but actually the governor of Missouri today, by executive order, decided that the state is going to have a PDMP because the legislature just could not get its act together. So what data do these collect? They collect patient information, prescriber information, and dispenser information for all Schedule 2 through, that should actually say 5 now. It used to be 4, and now I'd say it's pretty much 5 across jurisdictions of the federal DEA schedules of drugs, controlled substances. And prescribers, pharmacists, law enforcement, and state medical boards can typically access these data. Almost always prescribers and pharmacists, and now state medical boards, law enforcement, not all the time. So the first electronic PDMP was implemented in 1991 by Oklahoma. They have really proliferated. So by 2013, I believe 46 states had them, and now 49, almost 50. And there are lots of different features of these programs, and so there's been a rapid evolution of this policy and the different features over time. And I'll give you a sense of that in a moment. So the prescriber's kind of in a quandary here, because we have these dual epidemics and concerns. One is the pain epidemic, and the other is the opioid crisis. And the National Academies of Sciences just came out with a huge report on the opioid epidemic last week, and they do a really nice job of laying out the need to balance these two issues that we have going on. But I actually think that PDMPs can help to address both of these simultaneously, which is one really great aspect of this particular policy intervention. Because, and I'll get to this, but some of the evidence suggests that when prescribers do use this information, that sometimes it actually encourages them to prescribe comfortably, that it makes them think, this is not somebody that I'm worried about, it's not a high-risk prescribing situation, I can prescribe comfortably. In other situations, it's gonna raise some red flags and make you think, I probably shouldn't be prescribing in this context. But and I wrote about this a few years ago, these barriers to PDMP use, and I think a number of these are still very prevalent in states, and is a number of reasons why Michigan actually revamped its system. So common complaints from clinicians include that this time is unreimbursed to check the system, that it's burdensome to enroll, that there's maybe incomplete data, that the info may be viewed as being not necessary or not as valuable as if I just sat down and had a conversation with my patient, and that there's a lack of clinical guidance regarding what to do with the information. The PDMP goals are multifold, and so we're really talking here about use of PDMP as a patient care tool, so the ability to identify doctor shoppers or potential misusers, to avoid harmful drug interactions, to adequately prescribe painkillers when there aren't concerns, but also there's these other silos of sort of using it as a surveillance and evaluation tool for researchers, also to track prescribing trends, also law enforcement, and really these programs started as law enforcement mechanisms, and they've evolved into these clinical tools. But that was the original purpose of them. So, and now law enforcement still use them to identify clinicians and patients with outlier patterns going on, and then also to substantiate, they use them as evidence in cases sometimes. So, a number of groups, including the Pew Charitable Trust and the Brandeis, has a center of excellence that actually is a federally funded center that helps with policy coordination and tracking of policy and also accumulates some PDMP data. They have identified what they call best practices, and I would call these somewhat evidence-based because they, I think my standard for what would substantiate evidence is fairly high. Those with asterisks are those that I think do have some formation in the actual literature, but I think from a theory perspective, we think a lot of these things are things we want to do. So they include prescriber use mandates, that you have to check the system, delegate access, so somebody can check on a prescriber's behalf, unsolicited reports sent to prescribers when their patient is using at a high rate, or sometimes when they are prescribing at outlier rates, improving data timeliness, streamlining enrollment to the systems, educational and promotional initiatives, integrating the data with health information technology, and finally enhancing the PDMP user interfaces. Now I'm just going to show you some maps to show you where the policy is. These are as of the end of 2016, and this group, PDMP, the TTAC, the Technical Assistance Center, that's affiliated with the Brandeis Center, and they have a great website, so you can actually go and check the status of a lot of different features of these programs. You can see that the operating agencies vary by state, so a lot of states have pharmacy boards in blue that are operating these PDMPs, but a number have licensing and professional licensing agencies like Michigan. A few in yellow still have the law enforcement agencies housing the data. Data collection frequency is an area where there's really been an improvement over time. I'd say if we looked at this like a couple years ago, it would have been frequency of data updates, and this is the frequency with which the data that is entered at dispensing is available to prescribers. It would have been more like weekly or less frequent, and now you can see in green, most states have a daily update. Michigan has, it's either 2 times a day or almost real time now, I believe. So that's been a vast improvement in these systems. Also, mandatory training of prescribers and dispensers. This did not used to be a component of these programs, and now you can see that about 15 states require prescribers to actually get training on these systems. Mandatory enrollment and then mandatory use are 2 really active features that states have really been jumping on the bandwagon to adopt in terms of enrollment, and states really believe these 2 features have really done a lot of work to increase use of the databases and have evidenced that within their own states. So enrollment, you can see that about half of states require enrollment of prescribers and dispensers, and I think Michigan might even be higher than that. or have a higher ed. I'd say the median enrollment is about 50% of DEA licensed prescribers, but Michigan, I think, might be even a little higher, but maybe Kim can speak to that. And then finally, this mandatory query by prescribers and dispensers. There's been a lot of attention to this. These are called these use mandates. And so more than half of states have these for prescribers now, but I will say there's tremendous variation in the nature of these requirements. So some states have a very subjective mandate. So they say when a prescriber suspects that there may be misuse or diversion, then they check, and you can see how that, from a legal perspective, doesn't sound too much like a mandate. But others have very objective measures, and so you have to check every time you prescribe an opioid for the first time to a new patient, 3 months for chronic treatment, and very few exceptions. So there's wide variation there. And finally, law enforcement. This is an active area, not maybe as relevant to clinicians, although I do hear that clinicians worry a lot about law enforcement being able to access these data because it could kind of prevent the optimal use from a clinical perspective. But I will say it's being actively litigated in courts as to under what circumstances should law enforcement be allowed to access these data. Should it just be an active investigation, or should it be a higher standard where they have probable cause, they have a subpoena, to actually access these data? In terms of the evidence, what do PDMPs actually do? The evidence suggests that PDMP awareness is actually quite high. There was a national survey in 2014 suggested that 72% of primary care physicians were aware of PDMPs. Some other studies that have looked at ED docs or other specialties that might use the systems even more suggest that even higher rates are aware, like 80 or 90%. But use in this primary care physician population was only about 53%. Using. I'd say that maybe on average it's about 50%, again, of prescribers are actually using the databases, but that varies, and those are of prescribers who are prescribing opioids, but it varies widely across states. And PDMPs do seem to impact prescribing behavior. This Ohio study listed first is probably the best one, although it was back in 2010. But it suggested that in 41% of instances, prescribers changed their prescribing practice based on the information. And a lot of the time, 39% of the time, that was to actually provide opioids when they felt more comfortable. 61% of the time, it was to provide less opioids. In terms of PDMP effectiveness, its impact on drug prescribing and health outcomes, there's a lot of growing literature base now, and a lot of the older studies were of less optimal designs. PDMPs were also very underutilized in those time periods, and so we have a lot of mixed evidence and results going both ways. I think the newer evidence is more robust and is studying actual specific PDMP features. Use mandates and registration mandates have been a focus here, and studies to suggest that both reduce opioid prescribing, that also use mandates reduce measures of doctor shopping and even overdoses among adults. There's another study that looked at robust PDMPs using a number of metrics, suggested it reduced overdoses, and I've looked at robust PDMPs and their impact on opioid prescribing, and show that it reduces at a population level opioid prescribing also. And these are all among Medicaid, Medicare, and commercially insured, so among all different types of patient populations at this point. I will say that we have not done very much yet in terms of potential unintended consequences, and I think this is an increasing concern, that we are seeing reductions in prescribing at a population level and attributable to some of these features, but we're also seeing these spikes in heroin overdoses, and so are we clamping down on prescribing and then shifting patients to other supply sources that may be more dangerous? This is just a graph to show you in Kentucky and Tennessee, 2 states that I studied. These are using interrupted time series designs, but we saw population level among a commercially insured population, reductions in MEDs prescribed. We saw reductions in potentially high-risk prescribing. We saw reductions in the proportion of the population that was actually receiving opioids. So significant effects of these, and at the time I wasn't able to look at sort of integration into EMRs and interstate sharing of data, but these included things like comprehensive use mandates, registration mandates, delegate access, frequent data updates. All of those types of features were included in Kentucky, Tennessee, New Mexico, some of the states that we looked at with robust PDMPs. So in conclusion, I think the strongest PDMPs do seem to be having an effect on opioid prescribing. Key program features include PDMP registration and comprehensive use mandates and delegate access, increased administrative staffing to support PDMP operations. We need to be able to administer the systems well, and then working with prescribers to really tweak aspects of the PDMP and make it user-friendly. I think on the horizon and what we need to evaluate now is interstate data sharing and integration with medical records that's now happening with greater frequency. I think, so we need more well-designed studies and to study these newer PDMP features as they pop up, and then probe the unintended consequences further. I also have some concerns about disproportionate application of this policy lever to different patient populations and how that might be happening. I think we can increase PDMP data for surveillance, monitoring, and research, and further use PDMPs for both patient safety and, as I mentioned, substance abuse treatment purposes. And from a policy perspective, I think this is an area where we think of, great state variation in programs and a lot of interstate activity, and where we start to think that a federal policy might be on the horizon or in the, could be a way forward. So I will stop there and turn it over to Kim. Thank you so much.
So we are going to have time for question and answer at the end. I want to take just a moment here. Caitlin, if you just wave from the back there. That's Caitlin Calso. She's the program manager for Michigan Open. I want to thank her for putting the event together today, a tremendous amount of effort into getting the CME, getting everything together, getting the food. There's a lot of effort put in. I also want to thank Kara Gavin from IHPI, the Twitter queen, who actually helped us really promote the event and really got the word out. And this is a tremendous, tremendous turnout. Next, I'd like to introduce Kim Gatica from the director of the Bureau of Professional Licensing, LARA, here at the state of Michigan, where she's the Michigan Automated Prescription Service Program is actually administered through LARA. Prior to being in a role in April 2015, Kim was the interim director of the Bureau of the Healthcare Services, and previous to that, she worked in government relations. She's also worked for the Michigan House of Representatives and worked as a Congressman Fred Upton in DC in his local Kalamazoo district. Kim reached out a while ago with the interest in coming here and talking to us today. We're really fortunate to have her. Thank you.
Thank you for having me here. And I'm going to preface this presentation by letting you all know I'm not a clinician, I'm not a lawyer, I'm just really more of a facilitator of the different programs that our agency runs and operates. And I'm really excited to talk to you about the Michigan Automated Prescription System. And so just a little bit of background about our agency. We were established back in July of 2015. And at that time, we combined all of our healthcare professions. We have 25 healthcare boards, professional boards, and regulation boards. And we added 10 occupational licensing and regulatory boards to our agency. And so to date, we have just over 758,000 licensed individuals that we license and regulate within our agency. We have 3 divisions within Bureau of Professional Licensing: we have enforcement, investigations and inspections, and our licensing division. And as Dr. Brummett said, our drug monitoring section is where our MAPS program is administered and housed. And that section focuses specifically on overprescribing, overdispensing, and drug diversion cases. And we use MAPS to help us in those cases. So a little background about MAPS. Precursor to MAPS was called the Official Prescription Program, OPP, which was eliminated at the end of 2002. And at that point, we collected CS Schedule II and anabolic steroids and tracked that information. And then through legislative change in 2003, we established MAPS. And it wasn't fully electronic at that point. What happened was requests for MAPS were sent by fax, and then our staff manually queried the system. So that was back in 2003. And then in 2005, we transitioned to having the data submitted online and a turnaround timetable about 48 hours for that information to be posted. And then it wasn't until April of 2007 is when data could be submitted online and everything was automated at that point. Our current system contains just over 120 million records. We maintain that data for up to 5 years. And those that are required to report to the system, so we currently do not have mandated use or mandated registration. We have mandated reporting by our dispensers, our prescribers who dispense these drugs, and then our veterinarians. And then just, let me go back, just to touch upon a little bit what was mentioned earlier about mandated use. There currently right now is a pending bill in the legislature, Senate Bill 166, which is tie-barred to 167. 166 is mandated use of the MAPS program, and it's there's very little exceptions to that mandated use, so it's pretty restrictive. So just want to make you aware of that. My understanding is that it's already passed the Senate and likely to go through the House, at least in the House Policy Committee, Health Policy Committee, the second week. They're back in session in September, and then likely we'll move pretty quickly from there through the House floor. Senate Bill 167 is a bill that refers to and allows for the boards to take appropriate sanctions for those prescribers who don't use the system once that mandated use becomes effective. And I think right now with that bill will not become effective once passed until January 1 of 2020, just so you all are aware. This is just a little historical perspective in terms of the amount of records submitted to MAPS per year. We had just almost 22 million records and dipped a little bit, just over 21 million last year. And then just to add on to the data, the overdose deaths in Michigan by year, we actually were able to get through DHHS epidemiology, the data up to 2015, and we overlaid that with some of the MAPS data. And we're currently working with our vendor, Appriss Health, to do the overlay data for 2016. So once we get that, happy to share that with you. But anyway, so this is just sort of a snapshot, and as mentioned previously, we are seeing, in Michigan an increase, so in overdose deaths. And despite the other trend that we're seeing in Michigan as well as in other states, a drop in the amount of prescribing of opiates. So it's kind of an interesting dynamic going on. So the requirements for MAPS reporting includes quantity, NDC, which is the National Drug Code, prescription issue date, prescription fill date, estimated day supply, prescription number, prescriber DEA number, and dispenser DEA number. And there might be some pharmacists in the room, so just want to point out, it's really critical whether you're a prescriber dispensing in your practice or a pharmacist dispensing these drugs, because you all are responsible for uploading the data into MAPS. And one of the things that we're finding, a common mistake, is the wrong DEA number associated with that prescriber. Another common mistake that we're finding with that data is attributing it to even the wrong prescriber. So and one thing that we've added to our system is the ability for prescribers to run self-reports, and I'll talk about that in a little bit, but just want to make you aware, for those of you who do dispense and for those of you who are providing that data, to try to get it as accurate as possible. So in June of 2015, the governor established the Prescription Drug and Opioid Task Force and made a number of recommendations in the area of prevention, policy and outcomes, regulatory, and law enforcement actions. And one of the main recommendations as it ties to MAPS was to either enhance the system or fully replace. And you can find the full report online on Governor Snyder's website. And as a result of that, the governor then in 2016 established by executive order the Prescription Drug and Opioid Commission, which Dr. Rebecca Cunningham, I don't know if I see her in here, but she's actually with U of M, and so she's provided a lot of expertise and has been invaluable to that commission. So as a result of those recommendations, and with our legislative partners, we were able to get an appropriations to fully replace the system. I think it was like 2.4 million, 2.47 million to fully replace, and then another 2.02 million to maintain this new system. So through RFP, competitive bid, we ended up securing Appriss Health's PMP Aware software platform, which is the same system that roughly 43 states, including Ohio and really our border states, use today. And so we launched that new system April 4th of this year. And one of the things that we did was, so for those of you who may not have an account, I encourage you to get an account with the system because it is voluntary for prescribers to use it. We did end up requiring all our current users prior to the launch to re-register to the system, because one of the things that we looked at was with the data of our users prior to launch, there were several practitioners who had multiple accounts. It was the same account, but multiple accounts. And even some of our board chairs admitted that they had 10 accounts because it was easier just to re-register than to reset their password. So the data was skewed, and prior to launch, we were about 36.2% registered users using the system of the total population of prescribers in the state of Michigan. But that's probably really skewed just because we found many people having multiple accounts. So we wanted to have as clean a data as possible, not only in terms of uploading, so we did clean out a lot of data that did get uploaded to this new system, but also asked that everybody just re-register, and then just so that way we have a more current accounting out of our total population of licensees. And then we currently continue to seek feedback from our stakeholders and our users so that we can improve the system. So as of June, as of last month, average response time, so when you query a patient report, it's about half a second, and where before it would take 5 to 10 minutes to query a report, so that's time saver there. And we had about 15,573 requests per day back during the month of June. And as of last week, July 13th, we have a total of 14,849 prescribers registered, 6,127 pharmacists, and 3,117 delegate users. This doesn't include also, we have nurse practitioners, PAs, I mean, there's a bunch of other, but we've more than doubled the number of active registered users since our go live April 4th, because at the end of April 4th, we had 14,246 active registered users. And I think we've actually surpassed the total number of registered users prior to the go live date. So now I'm going to kind of get into a little bit of walk you through the process and the system. And I'm going to try to go through this quickly, but feel free if you need me to slow down or if you have questions when I go through the screenshots, just pipe in and ask. That's not a problem. So one of the things for those of you who have not registered to the system, you'll want to have your DEA registration ID number, because I'm sure you all have not memorized that. You want your license ID number. You'll want your controlled substance license ID number. Sometimes, I will say, your license number may be the same as your controlled substance license ID number. I think in 2007, the department had to make a change in how they did the numbering. So you may have a different one, or you may have the same number, depending on when you got licensed. And then you also want your national provider identifier, NPI number, with you. It'll just make the registration process much quicker when you have those readily available at your fingertips. So when you go and log into the system for the first time, this is the page that will pop up, and you have to provide your email, set your password, and then you want to create an account. And then once you do that, then it just takes you through the process where, again, you just, what is my registration process? Hold on. Okay, I double slide there. Sorry about that. So once you do that, then it'll take you to this screenshot where you have to identify yourself as either a healthcare professional, law enforcement, or other. One little caveat I want to mention about law enforcement, I want to clarify, because sometimes I think we use the term access a little bit loosely, particularly when it comes to law enforcement. So I just want, for those of you who are practitioners, not to be fearful in the sense of law enforcement does not, as of today, could change with the policy change, they do not have unfettered access. and they don't have the same level of access that our providers and prescribers have. So I just wanted to make that clarification. And when we talk about law enforcement access, we're actually referring to, for Michigan in particular, if you look at the Public Health Code under MCL 333.733A, there's a provision in there that allows for law enforcement, for those that are enforcing the drug laws of the state or federal government, or investigating, have a bona fide drug-related investigation. They can request information from the MAP system as long as they meet that criteria, and at which point we, our administrators, approve that and make sure that it's consistent with the statute. So just wanted to clarify that so that they're not looking at all this, raw data, patient data and information. So, so once you click on healthcare professional, one of the things that it'll take you to the next screenshot, which will be, to provide your specialty area and some other information. But it's at this point too, I wanted to note that for a delegate user, if you have a delegate user, they can't register under your account until you've signed up. So they have to provide your name and email address. And it's sort of like Facebook. So they're kind of Facebooking you and saying, hey, I want to be a delegate user under you. And you have to hit accept and have to have your account set up to be able to do that. So then they can create their own password username. You can maintain their account. You can add and delete delegate users as the prescriber and the provider having that account. So once you get through the whole process, this is just an example of what first time, this will be your dashboard. It's my dashboard. And at the very top, if there's any patient alerts, those will appear at the very top. And then any recent reports that you might have run, and then your delegate accounts will be underneath, so you can maintain those. And again, this is, if you click at the top menu bar, you can click over and to My Profile, and that just shows what you provided in terms of your specialty information, your contact information, things like that. And again, your delegate information too at the bottom. So when you're going to the system and you want to do a patient request, you click on the menu bar and click on patient request. And typically what you do is you provide first name, last name, date of birth, and anything that's an asterisk is required. One of the things I'm going to point out is that you'll notice off to, it's my left, but probably to your right, is the PNP interconnect search. One of the new features that we added to the system was a partial name search. So if you do a partial name search, that PNP interconnect will go away. It's a security protocol. So in order to query other state PDMPs, so like Ohio, typically Michigan practitioners will query Wisconsin, Indiana, Ohio, Illinois, border states. You have to submit the full first name and last name in order to query those other state PDMPs. Like I said, it's just a standard that was put in place for security with interstate data sharing. But if you don't want to do that and you just want to do a partial name search, you can do that as well. But I just wanted to mention that. So one of the things that when you do a query and you run a report, if there's a patient alert, that'll appear at the very top of the report, and you can click on to get additional information about that patient alert. A patient alert would be somebody that's maybe doctor shopping, has seen a doctor, several doctors in a short period of time, say less than 6 months or 5 months, and has been also dispensed a high volume of controlled substances. So that's just something for, hopefully as a practitioner, you'll see that and say, okay, I need to maybe ask some important questions of this patient and see if maybe they have a substance use disorder and maybe get them and route them or refer them to treatment and so forth. And then at the bottom, you'll see the standard report. It's kind of linear. That's pretty typical. That hasn't changed a whole lot. One other new feature that we've added into the system is bulk patient search. So this is very useful whether you're a practitioner or your delegate users. They can take a list of like an Excel spreadsheet of patient names, and they can actually upload it to the system, but rather than keying in, say 50 patient names every time to do a search, it'll kick back, if those patients are in the system, it'll kick back a list to you of those patients if they're in the system in their reports. So this is the feature I mentioned earlier about self-reports. And this is something that we really encourage you as a prescriber to run these self-reports. Your delegate users cannot run self-reports on you. So as a prescriber, you can run these on yourself. And we've actually already seen some benefits of that. Actually, I think the second day of the launch, I received an email from a physician who said, hey, I ran a self-report, and yes, I prescribed this particular drug to this particular patient on these dates, and it's pretty consistent. However, on this date and time, I did not prescribe these drugs. And so we were able to, we work with the pharmacist that keyed that in, and we got it corrected. The value of that is one of my big objectives in running this agency has been to work with our associations, our professional associations, and our health professionals to be in compliance. And because I'll tell you, it's a lot more costly and a lot of time to conduct these investigations, and we always have to try to get it right because cases can be appealed. That adds cost to the whole process. So our goal has been to try to do more education and to try to get everybody to be in compliance. And sometimes mistakes happen and it's not in your control. And so, rather than us take disciplinary action and then have it be dismissed at the end because we discover, well, it was really the dispenser that keyed it in wrong or whatever it might be. But anyway, so it's proving to be valuable because we've had since then more communication from our prescribers that literally identify and say, hey, this report's wrong. I didn't prescribe this. And so we get it corrected. So just something that, we built in there to help you all as prescribers to verify what you are actually prescribing. So next steps for MAPS, we have phase 2 enhancements. We're currently in that process right now. We have a Bureau of Justice Administration Harold Rogers grant to pilot integrations. We also have, from the same federal agency, a grant to provide provider scorecards, and I'll show you a sample of that. And then we partnered up with DHHS on a CDC grant to create de-identified reports. It's actually more indicator reports, and those have actually been completed now. And we are adding clinical alerts hopefully in the next week or two. And clinical alerts are actually they take the patient alerts and they're a little bit more robust, but it also includes MME equivalents and some other data sets that's hopefully will be helpful to you as clinicians. And then we are in the process, so this week, Monday, we were supposed to launch our new licensing and regulatory platform for nursing program. We currently license 190,000 nurses in the state of Michigan. We ran into a little glitch, so we're gonna probably be doing that tomorrow, actually go live. But we had to integrate with our new system to validate those who register to the system. And then we are currently in the process of doing statewide integrations with our EMR and pharmacy dispensation systems. And this is just an example of our provider scorecard. And I can provide more information to U of M that can be shared. And then this is our clinical alerts preview. Again, this is where a prescriber must be registered to MAPS to receive these alerts. The alerts will appear on the user's dashboard. And again, notification will be emailed indicating that there is a new alert available. And the alerts include patients receiving concurrent opiate and benzodiazepine within the same period, patients who meet or exceed prescriber or dispenser thresholds within a time frame. Patient sees 5 or more prescribers and 5 or more dispensers in 6 months, for example. Patients who meet or exceed daily MME equivalents. So jumping to the integrations, one of the things that we're doing, whether a physician group practice, healthcare system, so a hospital or a pharmacy, we're focusing on those professions right now for the statewide integrations. And so for those who integrate, whether we cover it through the BJA grant or through remaining dollars that we had, which was about 1.8 million from the replacement dollars that we received from the state, we are taking those monies, so it's just over 2.1 million, that's going to cover statewide integrations with electronic health record systems and pharmacy dispensation systems. So this screenshot just gives you sort of a generic view of how that would look when you integrate MAPS to the EMR. Pharmacy dispensation system might be a little bit different just because they're set up a little bit differently, but it's similar in the fact that if you look to your left of the screen here at the top, it says NARCS Care. So that's basically if that patient, Stephanie Marshall, is in your system and they're also in MAPS, that report will auto-populate into your EMR system. And then you can click to see more information. But the data that you're going to see right off the top is risk scores. So that's something that will come with NARCS Care. One of the things with the PNP Aware platform, it currently doesn't, you just basically get, this linear list of all this data in terms of what a person's been prescribed or dispensed, but it doesn't break it down in terms of risk scores, NARCS score, all of those things. So with NARCS Care platform, for those that integrate, they will get that automatically. It does break it down and provides you risk scores. So when you click on that says show report, this is what you're going to see. And I had to sort of break this into several screenshots, but it's really one screenshot for the purposes of this presentation. So at the very top, this is what you're going to see: the narcotic score, sedative, stimulant, overdose risk score, red flags, so any potential concerns about this patient, and then you get more of a visual graph over a period of time, what they've been prescribed and so forth. And then it continues with the MME, and then again, a listing, which is what's current today, the listing of all the prescriptions, the pharmacies, I think the prescribers, providers, and then pharmacies that they've gone to. And then when you click on, so at the top of the bar for those reports, when you click on NARCS Care Resources, it'll take you to a page like this, where you can actually, as a prescriber, if you suspect this patient might have a substance use disorder, or maybe you want to get them into an MAT program, you can do a search to find, the closest MAT provider or substance use disorder provider and refer that patient. And then there's some additional resources, kind of flyers, pamphlets that you could print off and give to the patient while you're treating that patient and seeing that patient. So really, again, the next generation for MAPS is NARCS Care, and our goal is to make, sort of going along the lines of what Rebecca was saying, is to make our state's PDMP more robust for the clinician, to make it more of a useful tool for the clinician. And hopefully by sort of breaking down that data and information for all of you, you can spend more time with your patient and ask those important questions that otherwise may not have the chance or opportunity to do so. So that's it. If there's any questions, you would contact technical questions with the system would be APRIS Customer First Center. And then any policy questions, you can contact our office. And then to get more information, you can go to our website and just click on the MAPS box. And then really just wanted to thank our stakeholders and our vendor. It's been a successful effort just because of our stakeholder involvement and our user feedback, and our vendor who, they're constantly enhancing the system. So, they're really listening to the states that they're in and providing this service. And I think, in terms of policy, I'm actually leaving here to go to Chicago to meet with all the state PDMP administrators with Interconnect, the NABP, National Association of Boards of Pharmacies, Interconnect, which is sort of like the hub for data exchange. And we're going to talk heavily about some standards for state PDMPs, because every state law is different, I'm finding, and it's been challenging with the interstate data sharing. So just because we have this sort of national hub and we have this mechanism to share data, because Kentucky, for example, doesn't let pharmacy technicians to access their system called Casper's, but Ohio does, states are kind of fighting over, well, because Ohio does, they should be able to access Casper. But so it's those kinds of things that I think you're going to start seeing more standardization, and whether that's done, from the PDMP administrators state by state, or hopefully that kind of, my guess is that it's going to come nationally, to be honest with you. So I think you're going to start seeing more national sort of standards for these PDMPs so that it makes that flow and exchange of information. I think another key piece, I've been talking to Dr. Bromet about a lot about research purposes. So there's a lot of value with having that information, and so if we can also make sure we include that element at the national discussion will be key too, because it doesn't help if we can only provide Michigan information to Michigan. It'd be helpful to sort of get a global picture too. So I think you're going to start seeing more of those kinds of discussions happen. And again, thank you all for having me here. Appreciate it.
So, if you don't mind, could you talk a little bit more about sort of the timeline with respect to the existing bills for those requirements, and maybe a little bit about what's happened in other states? One of the common questions I get from providers is about what happens if I don't. And I know that's a challenging question, but like, have we seen what these policies have done in terms of those? We know there are stubborn providers. What happens for those providers that either don't enroll or don't check their PDMP?
Yeah. So that's a really good question, because I've actually gotten that question from policymakers. It's always a challenge. I'm just going to be honest. I think the states that have mandated use and registration have about anywhere from 60 to 80%, more like probably 70 to 80% registered and usage of their state PDMP. And I think a lot of states leave it to their boards to issue those sanctions, and that's sort of the direction. And when Senator Shoemaker was drafting these bills, the original version was it's an automatic felony if you don't use the state's PDMP. We along with the Attorney General's office pushed back, and we said that's pretty harsh, because even with fraud or criminal sexual misconduct, some other more egregious types of acts, it's not that severe in terms of your license, sanctioning your license that way. So the feedback we gave was there's provisions already that allows for the boards to take the appropriate sanctions based on whatever that violation is. And so that's thankfully what Senate Bill 167 does. And I think a lot of states are, it's more, they leave it up to the boards to issue the appropriate sanction. And when I say appropriate sanction, it would probably be continuing education on how to use the state's PDMP, or continuing education on appropriate prescribing, things like that. So I think that's the kind of sanctions you're going to probably see. And I think that's typical for a lot of states. Rebecca might have a better perspective on that, because I haven't really followed it. But I think the Senate Bill 167 is a lot more reasonable, because ultimately you don't want to discourage prescribers or create this element of fear. You don't want to do that. I mean, that's a no-win situation for everybody. So I think the latest version is a lot more reasonable in that regard. I don't know if
the
you had
timeline then was again, it was 2020, is that correct?
Yeah, so the timeline, so right now, in terms of the bill probably going through the legislature and then signed by the governor, it's probably going to happen sometime in September in terms of making it through the House side and then go to the governor. And right now, the bill is effective, both bills would be effective January 1 of 2020. And one of the reasons for that was so that we would have a little time to do integrations. So that was why we did that. And is that Dr. Verney, our former Board of Medicine chair? Welcome.
Yeah, I think the version, I don't know if this is the latest bill, but that I saw was along the lines of the first infraction would be CMEs, and then a second infraction would be potential suspension of your medical license and things like that, which I think was quite reasonable because you've been on notice. I think other states, a lot of states do the medical boards. I think New York has the stiffest penalties I've seen where you can actually get prison time, but my understanding is that that's never been enforced. So sometimes the potential penalties I think are stricter in law than in practice.
Yes.
I know it's early in the development of the NextCare integration. Are there plans to integrate other states' PDMPs into the report, or is it just limited to?
So as far as the integration piece, that's actually a good question. I'll have to ask, because that's getting a little technical in terms of, no, it's not. I believe the way it would work is that you still would be able to do searches of other states' PDMP. I'm just not sure how that's going to appear in the new system, so.
We met with APRIS last week.
That's Friday.
That was last Friday. There does appear to be, there's definitely the capability to do that, and they've sort of, as they're mocking up these dashboards or these feedback pieces, they not only include other states, but they include other sources of data, like criminal activity, overdose history, things that may not really always come straight to mind, but at least might be there on the back end, may require additional policy or oversight in terms of whether or not those are appropriate. But this is where I think the field's moving is to stop stop giving you simply prescribing data, but prescribing data and patient data that goes beyond the prescriber and the number of pills. And I think that's when that overdose count, that overdose risk score was that mock-up actually does include some of that data.
And if I may, the other piece too is that with Narcs Care, you can do care notes. So, if say a patient is like in a coordinated care team, you can do care notes to each other in the system. And you can also see if they're on a pain management plan, for example. So if you're managing their pain, you can see that piece of it. So it's really, in some ways, sort of taking your chart where the PDMP is kind of like, second, it's really sort of taking the PDMP and putting it central, and then you kind of have all these other elements and sort of connecting all the dots, sort of making it full circle a little bit. So.
Other questions? So, yeah, hi, Mike.
I guess probably a question for Rebecca. So, states who have really bolstered their PDMP, is there any specific data on the implications on overdose within those states? So
On what's happened to overdose?
yeah, or increase in overdoses?
For increases,
So for example,
I haven't seen that yet. I think that's probably the next studies that are coming down the line is, increases in particularly illicit heroin and fentanyl-related overdoses, and whether that, and I also would say probably pain clinic laws and shutting down pain clinics, because those are really the two state interventions that have been shown to clamp down on prescribing, and whether those are shifting people to this other drug supply. I wouldn't be surprised.
We may not call those pain clinics.
Oh, yes, okay. Right.
Other questions? Yes.
Just for Rebecca, is there also going to be, with the increase in the heroin, is there some tie to, treatment facilities or referrals to treatment, or those patients that are identified that need treatment? Are we going to have that level of data, especially the SUD treatments?
The tricky thing with the heroin, I mean, the PDMPs are amazing in that they have all of the prescribing across the state and often within a state and often across states. And we struggle with this in research too, and studying this is that we don't have a really good source of actual heroin use except self-reporting in survey data, and then also looking at the heroin sales. And so if we can get any kind of metric on that, but it's illegal, so it's really hard to get a sense of how much people are actually purchasing those substances and using them. It's not going to be in a PDMP. I'm sorry, but overdose from heroin we can look at, because we can look at cause of death using CDC Wonder and other drug index data. And yeah, we can definitely look at that, but the use is going to be pretty limited to self-reporting.
And Kim, on the profile, it indicated the users, and there was another category that said others. Who's included in the other?
The other would be benefit plan managers. So that's how we identify that.
Kim, I just have a question about if the state requires providers to check prior to prescribing a controlled substance, and we integrate this into the system, and anyone can basically get that data, has the state come up with a plan for how we're going to prove that the physician reviewed the information so they're compliant?
So just I think one of the things, a lot of, just because we don't have the manpower or the resources to check everybody, just so you know. But what'll typically happen is if, say we get a complaint filed, it's a lot of times, and Dr. Bernie's familiar with this process, a lot of times we will get a complaint by somebody, whether it's the employer or by a colleague, a peer, and they might say, you know, hey, just alert you, this prescriber is prescribing all these drugs and they're not checking the state's PNP or whatever. I mean, you know, so I think in some ways that argument is sort of going to be diffused to some degree when you do the integrations, because it's there. I mean, it's whether you want to look at it or not, it's coming up. It's going to be in your screenshot when you're in the EMR for that patient. So I think in many ways it is going to be somewhat diffused, because, and then we have enough audit trails too, that you know, can verify that if somebody were questioned on it. I think it's, to be honest with you, I think what you're going to see more of down the road, I mean, yeah, mandated use seems to be kind of the popular sort of position right now across all states, but I think when you do integrations, that mandated use thing is really kind of moot at that point, because it's already there. But I think the key is looking more at, you know, and this is probably more for, you know, the health systems to sort of look at, and, you know, the universities to come up with policies or whatever around, you know, what do you do with that information? You know, and if you're seeing patients and still prescribing them a combination of opioids when they are clearly they have a substance use disorder, and you're just feeding into their disorder, that's probably more of a problem and an issue that probably needs to be addressed for, in terms of education and how to address that.
I think one of my concerns or questions about the algorithms, you know, that create these alert pop-ups is, you know, and they vary from state to state, is my understanding. We don't really have a general agreed upon definition of doctor shopping, for example. And so, you know, so really being transparent about what those thresholds are, and then really being careful to think about, you know, are prescribers just going to rely upon those alerts and not use their own clinical judgment? And if an alert doesn't happen to pop up, still be thinking actively about, you know, is this a potential risky situation? Because, you know, it's kind of like you reliance on, you know, technology that's there, and almost going in the flip side and like relying too much on the PDMP information.
Yeah, that's a good point. One of the things that I've tried to stress is that, you know, MAPS is just a tool. You know, it's not the end all be all. It's not going to solve this problem. I mean, there's multiple factors, but it's a tool. And so our goal is to try to make it as helpful and useful to you all as users of it. But that's a very good point, because, you know, if you make it too easy, then are you just going to rely on that and not, you know, take a closer look?
It's not clear currently whether those algorithms are going to be public. In other words, whether that APRIS algorithm is, you're actually going to know what's behind that. We've talked about developing some of those algorithms here at the University of Michigan. Obviously, those will be publicly available, and maybe we can produce them together, and then they can be public. Kara.
Thank you for coming. My name is Karen Morgenstern. I'm in the Office of General Counsel, and I appreciate your time and your dedication to this challenge. I couldn't really see the provider scorecard, but I am interested in building on your point. One of our interests is identifying, well, we have an obligation, and the medical staff does, to monitor professional behavior, and that includes prescribing practices. So we do collect some data, but having access to that scorecard, not in the law enforcement capacity and not fitting the other categories, it would be helpful if there might be an opportunity for a peer review body to be able to access that for that function. And I just wondered if any states are allowing that, or, and again, it's to intervene on behavior much upstream and not ever get into that category of law enforcement or throwing around felony, certainly.
So the provider report cards are actually generally new. Virginia just launched theirs about a month ago. We'll be launching ours this month. So, you know, and I'm just trying to think, there might be one other state that has those. So we asked APRIS Health to develop that. You know, there's always that fine balance in the role that we play as a licensing and regulatory agency of, you know, balancing and equipping our practitioners with what they need in terms of, you know, this subject matter, as well as working with law enforcement and partnering up with, you know, whether it's DA, MSP, you know, the Attorney General's office, OIG, Medicaid agency. So we, you know, we're very well aware of trying to sort of find that balance. One of the purposes of these provider scorecards is really for the practitioner to see where do they fall amongst their specialty area in terms of prescribing of opiates. So that's what that was meant for. And hopefully, you know, if somebody is sort of like an outlier, that prescriber will maybe take some initiative and be like, hey, you know, maybe I need to figure out what's going on here, talk to my peers and colleagues, why am I seem to be above that threshold. Because I will say, you know, we're very well aware of the information, and we did suspend the number 2 prescriber in the state of Michigan. We did not suspend the number 1, and the reason being is that the number 1 was practicing within the norm in terms of prescribing of opiates. So, and based on their patient volume and patient relationship, and, you know, we look at a number of factors. So, you know, it's easy to say, well, you know, we want all of these reports for this purpose, but, you know, we really are sensitive in trying to balance that. But certainly, you know, happy to take your card and, you know, we can work that out. You know, I know, I'm not sure what Virginia does by way of providing that information. Again, every state's different in terms of what they can and cannot share with law enforcement. Michigan's a little bit more flexible and broad.
Okay, one last question.
Thanks, Kim. My question's around discussions about inpatient or acute care prescribing of opiates and controlled substances and reporting that. At one point, there was discussion of that, and it just makes my head spin to think about that. But it's not, you know, beyond the stretch of the imagination to just say, oh, it's data, and somehow feed it into the system. So I mean, just think about every single order for a controlled substance for an inpatient.
There was discussion about that, and I don't know where that landed in the bill, to be honest with you, so I have to go back and look at the latest version of the bill. I think they took it out, so just because there's a federal regulation on that as well that exempts it. So I think that was taken out, but I'd want to double check that, so.
Well, thank you, everybody. Thanks for coming out today in the afternoon. Thank you very much for coming. We really appreciate it.